Welcome to the deep dive. We take interesting sources you send us and, well, we pull out the core insights.
Yeah, the idea is to get you up to speed quickly without you having to wade through everything yourself.
Think of it as the essential info, fast.
Exactly.
So today, we're looking at something a bit different, a medical case study. It's titled Beta Blocker Overdose Management.
Now, hold on. Even if medicine isn't your thing, this one's actually fascinating. It gives you a real window into crisis situations, how the body reacts.
And how doctors problem solve under pressure.
Right. So the case about a 28-year-old guy, no real medical history, who ends up in the ER after a witnessed suicide attempt.
He apparently took some green pills. That's all they knew initially. Pills belonged to his grandmother.
And that's the first big question mark, right? What were the green pills?
So our mission for this deep dive is basically to follow the clues. How did the medical team figure out it was a beta blocker overdose?
And crucially, what did they do about it? We'll look at the challenges, the treatments, what makes this kind of overdose tricky.
Okay, sounds like a plan. Let's dive in.
All right, so when the patient first gets there, his vital signs are interesting.
How so?
Well, his pulse is low, 45 beats per minute, but his blood pressure is 116/85, which, isn't alarming on its own.
And the report even says he looked well initially.
Which is kind of strange given the reported overdose. It highlights that initial uncertainty.
Definitely. And this whole green pill thing, neither the patient nor his girlfriend knew what they were. That must made the diagnosis really difficult at first.
Oh, absolutely.
Yep.
A huge differential diagnosis, as they say. You have to consider so many possibilities.
So what did they do? Just start running tests?
Pretty much. They ordered a whole battery of initial labs. CBC, Chem10, that's electrolytes, kidney function liver test.
Standard overdose stuff like acetaminophen, salicylate levels?
Yep. Plus a venous blood gas, urine analysis, and EKG to check his heart.
Okay.
And they were waiting on a urine drug screen and a chest x-ray as well, casting a wide net.
Makes sense. But given the report of an overdose, they kept him on continuous monitoring, I assume.
You bet. Smart move, because things can change fast. And they did.
Uh-oh.
Yeah, while they're waiting for those first results, his condition just tanks. Pulse drops way down to 30.
Wow, 30.
And his blood pressure plummets. They could only measure it by feeling the pulse 64 systolic by palpation. Big change. Real alarm bells now.
Okay. Critical situation. But then something shifts, right? Information comes in.
Exactly. This is the turning point. Just as things are getting really serious, the girlfriend arrives.
Yeah.
And she has the grandmother's medication list.
Sure.
Crucial piece of the puzzle.
Ah. So they could finally figure out the green pill.
Right. The pharmacist looks at the list, identifies a green pill. It's Inderal, which is propranolol, a beta blocker, 40 milligram dose.
Okay, so now they have a prime suspect. Beta blocker overdose.
Suddenly the picture becomes much clearer, and they can target the treatment.
So what's the first move now that they know, or strongly suspect, it's propranolol?
Well, the case study says they gave him activated charcoal right away.
Okay, that makes sense. He only took the pills about 20 minutes before getting there, right? So the charcoal could still bind some of it in his stomach.
Precisely. Acts like a sponge, stops more drug from getting absorbed. Then they gave atropine.
Atropine. Isn't that for slow heart rate? Bradycardia?
It is. It tries to block the signals that slow the heart. But with beta blockers already blocking heart receptors, atropine often doesn't work that well. Worth a shot, though.
Okay. What came next? I saw glucagon mentioned prominently.
Yes, glucagon is really key here. It's often considered a first-line antidote.
Why? What does it actually do against a beta blocker?
It's pretty cool, actually. Beta blockers slow the heart by acting on specific beta receptors. Glucagon basically finds a back door.
The back door.
Yeah, it activates a different pathway inside the heart cells, bypassing the blocked beta receptors altogether to increase cyclic AMP.
Which does what?
That increases the heart's contractility, so how hard it squeezes, and also the heart rate. It directly counteracts what the beta blocker is doing.
Gotcha. And the case mentioned something pretty vivid happening after the glucagon.
Oh, yeah. He actually vomited, and apparently they saw the black charcoal and green pill fragments come up.
Wow. You can just imagine that scene in the ER.
Definitely paints a picture. But even after vomiting up some pills, his blood pressure and heart rate were still dangerously low.
So the glucagon bolus wasn't enough.
Not on its own. So they started a continuous glucagon infusion, a drip, to keep the levels up. And they also gave him calcium gluconate.
Calcium. Why add calcium into the mix?
Good question. Think about basic muscle function. Calcium ions are absolutely essential for muscle contraction, including the heart muscle.
Okay.
Beta blockers can interfere with calcium's role, weakening the heart's pump. So giving extra calcium can help boost that contractility, that squeezing force.
Does it help the heart rate too?
Not usually. Not significantly in beta blocker overdose. It mainly helps improve blood pressure by making the heart pump stronger.
Right. But the treatment didn't stop there. They added high-dose insulin. That sounds counterintuitive. Insulin for a heart problem.
It does sound weird at first, doesn't it?
Yeah.
But this is a really interesting aspect of overdose management. High-dose insulin therapy, or HDI, is increasingly used.
How does it work?
Well, the exact mechanisms aren't fully understood, but there are a couple of leading theories. One is that in a shocked state, the heart muscle struggles to use glucose for energy. High-dose insulin basically forces glucose into those heart cells.
Giving them fuel to work better?
Sort of, yeah.
Yeah.
It might also have direct positive effects on heart muscle contractility itself, an inotropic effect.
Yeah.
But because you're giving so much insulin.
You have to give glucose too, right? To stop his blood sugar crashing.
Exactly. They run a dextrose infusion alongside it constantly, monitoring blood sugar very closely.
Okay, that makes more sense. And then epinephrine.
Yep. They started an epinephrine drip next. That's a more standard approach for low blood pressure and slow heart rate.
Like adrenaline, basically.
Right. It hits both alpha and beta receptors. So it constricts blood vessels to raise blood pressure, and it stimulates the heart rate and contractility.
But the beta blocker is still blocking those beta receptors.
Which is why they often need much higher doses of epinephrine than usual in these situations. And the case notes they actually considered another treatment here, lipid emulsion therapy, but poison control advised holding off initially.
Okay, so a lot of interventions happening. Glucagon, calcium, insulin, epinephrine. Did things start to improve then?
There was maybe some initial improvement, but it didn't last. Unfortunately, he had a setback.
What happened?
His heart rate dropped again. Blood pressure fell again. Still unstable despite all those treatments.
So back to the drawing board. Or did they revisit that lipid idea?
They revisited the lipid idea, intralipid or intravenous fat emulsion.
And why did they decide to go for it now?
Well, propranolol, the specific beta blocker he took, is known to be highly lipophilic.
Meaning it dissolves well in fats.
Exactly. So the theory behind intralipid therapy is called the lipid sink theory. You infuse this fat emulsion.
And it acts like a sponge in the bloodstream.
Pretty much. It creates this fatty compartment in the blood that basically pulls the lipophilic drug, the propranolol, out of the tissues, like the heart and brain, where it's causing toxicity.
Huh. That's clever.
It is. There might be other benefits too, like providing energy substrate to the heart. And the case report mentioned there were positive reports in other severe cases, so that likely pushed them to try it.
And did it work this time?
It seems like the combination did. After starting the intralipid, while also continuing to adjust, probably increase, the epinephrine drip,
He finally stabilized.
he finally stabilized enough to be admitted to the ICU. It really shows how you sometimes need multiple, even unconventional approaches layered on top of each other.
Absolutely. This case really pulls back the curtain on managing these complex overdoses. What are the big takeaways then, the key learning points?
Well, first off, like we saw, you have to consider a beta blocker overdose in anyone presenting with significant bradycardia, that slow heart rate, especially if they're altered or unstable.
Even if they don't initially mention taking anything.
Especially then. Patient history in overdose is notoriously unreliable. You need to dig deep, talk to family, paramedics, check pill bottles if possible, get collateral information.
And run those standard labs to rule out other causes or co-ingestions.
Right. The second big point is understanding how these drugs cause toxicity. Beta blockers are designed to lower heart rate, blood pressure, contractility. In overdose, those effects just go way overboard.
Leading to the severe hypotension, bradycardia.
And potentially other things like hypoglycemia, trouble breathing, CNS depression, confusion, coma, even seizures, and dangerous heart rhythms.
And you mentioned earlier that not all beta blockers are created equal in overdose, right? So sotalol and propranolol were highlighted.
Super important distinction. Sotalol has additional effects, blocking potassium channels, which can prolong the QTc interval on the EKG. That increases the risk for a nasty arrhythmia called Torsades de Pointes, and its toxicity can be delayed.
Okay, so sotalol is tricky for that reason. What about propranolol, the one in this case?
Propranolol is tricky for different reasons. It has what are called membrane stabilizing effects, meaning it blocks sodium channels, similar to some other antiarrhythmics.
And how does that show up?
On the EKG, you might see a widened QRS complex, sometimes a specific pattern with a tall R wave in lead AVR, which is a bit of a red flag. This sodium channel blockade is also thought to contribute to the higher risk of seizures and CNS issues with propranolol.
Because it affects nerve function too.
Potentially, yeah. Interferes with synaptic function. And a general point in overdose, even beta blockers that are normally cardioselective lose that selectivity. They start blocking beta receptors everywhere.
Got it. So the EKG is a really valuable tool here. Slow rate, maybe a long PR interval generally.
But then QRS widening points towards propranolol.
Yeah. While QTC prolongation without QRS widening points more to sotalol. Specific clues.
Exactly. It helps guide management.
Okay, so let's talk treatment again. If someone's stable, just maybe took a bit too much, what's the approach?
If they're stable, alert, and it was a recent ingestion, say within an hour or maybe two, activated charcoal is the main thing to consider. Try and prevent absorption.
Simple enough. But for the unstable patient, like our case, it's a multi-pronged attack.
It really is. A stepwise, but often simultaneous approach. First line, as we discussed, is often glucagon. Bolus dose, then continuous infusion.
Bypassing the blocked receptors.
Right. Then high-dose insulin with that essential dextrose cover.
For energy and maybe direct heart effects.
Calcium next, usually calcium chloride or gluconate, mainly to boost contractility and blood pressure.
Okay.
Then vasopressors. Epinephrine is usually the go-to first, acting on alpha and beta receptors. But remember, you might need high doses, and it shouldn't necessarily be the only pressor used if it's not working well enough.
Are there other options besides epinephrine?
Yes, things like norepinephrine or even dopamine could be considered depending on the situation. And they mentioned milrinone.
Right. What's the thinking there?
Milrinone works differently. It's a phosphodiesterase inhibitor. It increases cyclic AMP in the heart muscle, boosting contractility, but through a pathway independent of beta receptors and glucagon. So it's another way in. And it tends not to increase heart rate as much, which can be good.
Interesting. What else is in the toolbox?
Sodium bicarbonate can be used if the QRS is very wide, particularly with propranolol, to try and counteract that sodium channel blockade.
Makes sense.
Atropine, as we said, can be tried for symptomatic bradycardia, but don't expect miracles. Cardiac pacing using external pads or internal wires to make the heart beat is an option for severe bradycardia, but it might not actually improve blood pressure much if the heart muscle itself can't contract properly.
And then the lipids.
Intralipid therapy, yes. Especially for lipophilic beta blockers like propranolol, particularly in severe refractory cases where other things aren't cutting it.
Yeah.
That lipid sink idea.
And the ultimate backup.
For truly refractory circulatory collapse, ECMO, extracorporeal membrane oxygenation, basically a heart-lung bypass machine, but that's highly specialized, needs early consideration and coordination with an ECMO center.
Wow. Quite the arsenal.
You need it sometimes.
So bringing it back to this specific case, the report concludes it was a success story, right?
It does. They emphasize that the rapid identification, once they got that medication list, and the aggressive, multifaceted treatment were key to the positive outcome.
And importantly, they also mentioned the follow-up psychiatric care he received for the underlying depression.
Crucial point. Treating the overdose is just the first step. Addressing the reason behind it is just as vital for long-term recovery. He apparently did well afterwards.
That's good to hear.
Mm.
So summing up this deep dive, beta blocker overdose, definitely something for clinicians to keep in mind with unexplained bradycardia.
Absolutely. Don't rely solely on the initial story.
Mm.
Dig deeper.
And the treatment isn't simple. It often involves a sequence or combination of glucagon, high-dose insulin, calcium pressors.
And sometimes advanced therapies like lipids or even ECMO, depending on the specific drug and severity.
The whole green pill becoming Inderal, leading to this cascade of targeted treatments. That's the real aha moment, isn't it? How one piece of information unlocked the whole puzzle.
It really underscores the importance of good detective work in medicine, especially in emergencies. Quick thinking, using all available resources.
And it makes you think, too, about how profoundly different a drug's effect can be at a therapeutic dose versus an overdose.
Completely different ballgame.
Understanding that underlying physiology, how the drug works, and how the overdose disrupts things is what allows doctors to choose the right countermeasure.
Exactly. It all comes back to the science.
Makes you wonder about other common medications out there, doesn't it? What hidden dangers might lurk in an overdose situation that we don't normally think about.
Yeah, it's a really good thought to leave with. Even everyday medications have a dark side if misused or taken in excess. A reminder of that delicate balance.
Well, thanks for digging into this one with us. It was a really illuminating case.
My pleasure. Always interesting to see medicine in action like this.
And to everyone listening, if you have sources, case studies, articles, anything interesting that you'd like us to explore in a future deep dive, please do send them our way.
We'd love to see them.
Until next time, keep asking questions.